Good day, everybody. My name is Amanda Nephew. I'm a master's student here at FAU in the Health Science and Health Promotions Department. Today we're going to be discussing the effects of mindfulness-based stress relief as a therapy for combat veterans with post-traumatic stress disorder. To start off with, we're going to go over the definitions and background information regarding post-traumatic stress disorder, the current therapies and treatments available, and also MBSR in comparison to other therapies. We're going to go over some of the background results they found in this preliminary and albeit limited research. And then we're going to touch on the purposes and the hypothesis of this research. We're going to go over the methods and the tests that we will administer. And then we're going to go over our limitations and discussion points. So post-traumatic stress disorder is made up of 4 symptoms primarily. These include hyperarousal, avoidance, re-experiencing, and negative mood and affect. So what we see in the research, it's a little bit mixed in some areas, and I'll touch on that later, but the consensus is that there are high levels of norepinephrine, there are low levels of brain-derived neurotrophic factor, or BDNF, there are elevated corticotropin-releasing hormone levels, and there's low cortisol. This would appear to be quite unusual since CRH is involved with the stimulation of acetylcholine, which leads to the stimulation of cortisol. So this makes the profile for PTSD quite unique. We also see that the hippocampus tends to be degenerated. This isn't always the case, and again, we'll touch on that later. The prefrontal cortex tends to be understimulated, which is a problem since the PFC actually regulates the amygdala to a degree. So the inactivity of the PFC makes it so the amygdala is overreactive. Additionally, they've done studies that have found that the anterior cingulate cortex appears to be hyperreactive, and this might be a predisposition. The hippocampus volume may also be a predisposition, but studies have been quite equivocal on that. There are different types of trauma and different types of PTSD. So as far as trauma goes, there is the trauma where you are experiencing something done to you, where you fear for your life, and maybe you've watched another person get injured that you care about. The other type of trauma is in regards to watching strangers go through something. So in one regards, you have a nurse or an EMT, and the others, you have police, firefighters, veterans. There's also comorbidities, and these comorbidities can confound some of these types, especially with depression. Depression has a different profile. Typically, they have higher cortisol levels and lower responsivity, but it appears that when depression is comorbid with PTSD, it creates a different disorder that requires different medical treatments. And so for that reason, our PTSD study will just focus only on pure PTSD, and it will control for comorbidities. Another confounding factor that we have is if trauma occurred at an early age, or if trauma has occurred multiple times. So trauma in early age can actually lead to changes in the HPA axis, which is the hypothalamic pituitary adrenal cortex axis. And these changes will persist into adulthood. That may display as the change in hippocampal size, and it may also display as the altered sensitivity of glucocorticoid receptors, which may be one of the reasons why we have high CRH and low cortisol. Before we move on to this, additionally, not put in this PowerPoint but notable is that norepinephrine appears to be elevated through sleep cycles, which may be a contributing factor to some of the sleep disturbances in PTSD, and we'll get more into that later. So, a current limitation that current treatments that we have. So, current treatments include the cognitive-based therapies, the eye movement desensitizations, and exposure therapies. Frequently, these therapies show a high rate of attrition, as well as people not wanting to start it, whether that's from fear of stigma of therapy or because they don't want to deal with that trauma experience at the start, which is a problem since avoidance is one of the primary symptoms. So Banks, Newman, and Salim in 2015 noted that attrition rates in CBT and the eye movement desensitization could be as high as 50%. Residual symptoms are also noted throughout these studies, and different types of PTSD may respond differently to these different therapies. So exposure-based therapy requires patients talking about their trauma, essentially reliving it, which is quite abrasive. So what they've seen is sometimes there's an exacerbation of symptoms in non-anxiety-based post-traumatic stress disorder. Lang et al. In 2012 noted that a third to half of the patients in these common therapy programs do not fully respond to these common treatments. And then additionally, Pelusny in 2015 with his colleagues noted that attrition rates were 30 to 50%, and this could be a dropout or a lack of starting in both exposure and cognitive-based therapies. 60% of the veterans we have coming over now from Operation Enduring Freedom and Operation Iraqi Freedom either do not start or discontinue therapy, which is an incredibly high rate. For this reason, the VA has started looking at alternate modes of therapy, which we will get into shortly. And then additionally, medications that are common for PTSD treatment include SSRIs, which are serotonin reuptake inhibitors, and then sleep medications. So touching back on what the VA is going for, because of the intensity of these treatments, MBSR poses an alternate because it doesn't involve trauma recall. Among veterans, there's a survey done by Pigeon and colleagues in 2014 that showed that 23 to 50% of veterans have used alternative medical treatments, and that 76% say that they would use it if it was offered to them. Mindfulness-based stress relief is essentially an incorporation of yoga, which involves gentle movements and stretching. It involves mindfulness meditation, both walking and sitting, and it also involves dialectic therapies, which essentially focus on intention, attention, and attitude. These therapies promote neural growth. They produce self-regulation. They have been shown to produce better coping strategies amongst people. And then also, they have, particularly interesting for PTSD, shown to increase the prefrontal cortex activity and then regulate the anterior cingulate cortex activity. So Lang in 2012 with colleagues noticed that mindfulness has a medium effect size, whereas Kearney in his 2012 study looking at mindfulness in vets noticed a medium to large effect size regarding the PCL, which is the PTSD checklist, the PHQ-9, which is patient health questionnaire, which assesses depression scores, and then FFMQ, which is the 5-facet mindfulness questionnaire, particularly important for mindfulness studies. For note, there are different types of mindfulness therapies. So mindfulness-based stress relief and cognitive-based stress relief are the two most popular versions of mindfulness therapy. The difference between them is that the mindfulness-based cognitive therapy focuses more on depressive symptoms, whereas the MBSR focuses on dealing with stress and hyperarousal symptoms and a number of other psychiatric issues. So in this study done by Libby, Pilver, and Desai, they assessed the common alternative medical treatments that are available to veterans in most of the VAs. So ranking at the top of all the other therapy types is mindfulness. And this is the most popular in outpatient and inpatient, and it's the second most popular in the residential programs. Notably, the VA tends to use research that has significant amount of evidence for it. The fact that the VA is using MBSR should be significant in saying that this does show some degree of efficacy, as it has in a number of studies such as arthritis, depression, cancer patients. There's a number of other studies, schizophrenia, but as far as the VA research goes, it's quite limited, especially looking at biomarkers. So Feldman and colleagues in 2016 looked at PTSD with MBSR treatment, and they saw that there was an increase even after discontinuation of the therapy that went to a medium-large effect size from 0.63 to 0.69 for PTSD, and from a 0.58 up to a 0.7 in depression effect. And this follow-up was about 2 months after the treatment ended. So notably, there's a picture here with the numbers. PHQ-9 again assesses depression, and the PCL assesses the post-traumatic stress. We'll see that re-experiencing and hyperarousal at 0.52 and a 0.65 effect scores are the most notable changes from MBSR in this particular study. A different study that looked at mindfulness-based stretching, essentially removing the dialectic component of this, just doing Tai Chi, which incorporates the slow movements and mindfulness of your own body. They found in a study performed on nurses with post-traumatic stress disorder that the mindfulness-based stress relief, or the mindfulness-based stretching, actually increased the cortisol levels from baseline, which in other studies on MBSR or mindfulness practices in general, they found that there is a decrease in cortisol. This is because those studies are assessing people with high cortisol levels. PTSD, again, is notable because of its low cortisol levels. So this study in particular suggests that the mindfulness actually regulates the stress hormones. The purpose of our study is to assess the efficacy of MBSR as a treatment for PTSD through both the assessment of psychological and physiological parameters. Especially on the physiological component, most of the research that's out so far, which again is limited, does not measure these biomarkers. The aim of this study is to assess male combat veterans to a control group, which is going to do treatment as usual, the CBT, the eye desensitization, exposure. We're going to take measurements pre, post, and at a 2-month follow-up. Our cognitive batteries are going to include CAPS and the CPL, which are going to assess PTSD, FFMQ to assess mindfulness, and the PHQ-9 to assess depression. Our biochemical measures are going to assess cortisol, BDNF, and norepinephrine. The hypothesis is that cortisol will increase, BDNF will increase, norepinephrine will decrease. The mindfulness will increase, but PTSD and depression scores should decrease. Our study is going to be comprised of 15 members in both the control group and in the MBSR group. They will only be male veterans, and they will be requested to not do any other psychotherapy outside of this practice, although they will be allowed to take their medications as normal as long as they've taken it for at least 2 months prior. There will be no comorbidities, as noted earlier, and there must be a full PTSD diagnosis, which will be assessed by the CAT score by a clinician. The structure of our test will have measurements taken a week before the 8-week intervention, and then the 8-week intervention will ensue. We will have a once-a-week, 2.5-hour MBSR session, and then between week 6 and 7, 7, there will be a 7-hour silent retreat. At 2 months post-measurement, we will take another assessment to see if there have been any further changes. The treatment as usual, again, will go off of whatever their primary care physician or therapist has prescribed them. Cortisol will be assessed through a salivary sample via the salivette tubes. We will teach the participants how to take these at home, and they will be measured at 5 different points: at waking, 45 minutes after waking, within 2 hours of waking, and then at 8 p.m. and bedtime. The norepinephrine will be measured through salivary MHPG, which is the primary metabolite of norepinephrine. And we're doing this because the plasma norepinephrine in some research has been shown to not be consistent with the central nervous system volumes, whereas salivary and urinary have shown more consistent results. And then finally, BDNF will be assessed via a blood sample taken at the antecubital vein, and it will be centrifuged and stored immediately, and then we will use a sandwich ELISA to determine concentration. Our primary means of measuring the cognitive components will include the PHQ-9. A reduction of 5 points will be noted to be clinically significant. In the CAPS and the PCL, a change of 10 points will be clinically significant. And in the mindfulness, this is there's no clinical significance. This is just to assess an increase for the benefit of mindfulness. We will use Statistica as the primary software for analysis. There will be 4 primary tests conducted. The first will be a Cohen's d between group effect sizes. We will do a student's t-test to detect differences between the demographics and the initial symptoms and biomarkers between the groups. The one-way ANOVA will be used to assess the cognitive components from the start to end of the intervention. And then we will do a 2x3 repeated measures ANOVA to assess the tau group with the MBSR group across the 3 time periods. Our limitations: this is only taking place in male populations, primarily to avoid the changes that may occur through female hormone changes. This is only in PTSD without comorbidities, and this is to see if there is a baseline effect. And then also, participants are allowed to continue with their medication for health purposes, but this could ultimately confound some of the results. Practical implications: this treatment is cheap and it doesn't involve recalling a trauma, and it's done in a group setting, which can increase the sense of support, which is notably low amongst PTSD and depression. And then additionally, this can improve the efficacy of other treatments like exposure therapy, or it can be used for people who do not wish to see a therapist or do not wish to take medications. And then that is our conclusion. This is our references. Thank you so much.